Welcome, everybody. My name is Richard Horton from the Lancet, and you are joining us for the launch of the Lancet Commission on the Future of Care and Clinical Research in Autism. Let me immediately thank our co-chairs, Catherine Lord and Tony Charman, and a really superb group of commissioners. I'd like to thank our funders, and I'd like to thank my colleague, Helen Frankish, who navigated the Commission so deftly through to publication. This report, though, that you're going to hear about over the next hour or so is much more than a typical Lancet Commission. It's really the story of our evolving understanding of a condition that causes a wide range of impairments in daily living. It's also, if I may say, an urgent manifesto describing an agenda for action over the next 5 years. The Commission has taken a life course approach and sets out a new standard of personalized stepped care. It moves away from simplistic diagnostic labels to assessing the unique needs and circumstances of autistic people and their families. The commissioners express both optimism in their thinking as well as realism. And I should emphasize that throughout the whole course of this commission, autistic people and their families have been involved at every single stage in reaching the recommendations that you will shortly hear about. Now, one challenge for the Commission, of course, is that many autistic individuals remain undiagnosed, especially in lower and middle income settings. And another challenge is that those with autism who have very positive outcomes are unfortunately still a minority. So the Commission has done something strikingly original. It has defined a new category of autism representing those with higher dependency needs who are unable to advocate for themselves. And I think this is a real step forward in trying to raise the profile of autistic people in the wider political and policy discussion. Ultimately, of course, it is though the responsibility of governments to invest in services, support, especially in schools, research, especially practical aspects of research. And of course, a further challenge faced by this ambitious call to action that you will hear about is the very severely constrained nature of the workforce, which must also be invested in if we're really going to take the subject of autism more seriously in our society. And that combines with the twin problem of systematic stigma throughout all of our discussions, which must be challenged directly. Indeed, this commission concludes with a real underlining of an absolutely vital principle, that neurodiversity is a feature of our society that really must be valued. This is a tremendous piece of work. I'd like to commend everybody for it. One piece of housekeeping before we move on, and that is that all of you are welcome to submit questions. Please use the Ask Question box on the dashboard in front of you. And now let me hand over to our co-leader, Catherine Lord, who is the George Tarjan Distinguished Professor of Psychiatry and Education at the David Geffen School of Medicine at the University of California. Kathy, over to you. I'm looking forward to hearing what you have to say. Thank you.
Hi, everybody. Welcome. I also want to begin with thanks first to our commission who really hung in. We had our last meeting literally before the world shut down with COVID and then have pulled this together from afar. And we also had incredible support from Lancet, particularly Helen Frankish and Flavia, and then you'll hear from Tony Charman, my co-leader. We come to you from a deliberately selected group of people from 6 different continents, different disciplines, including autistic people and parents of autistic people, researchers and clinicians. I think our first point is urgency. I mean, in this world right now, while we're dealing with COVID and Russia and all the things that are going on in the US news, at least, and I think even in the world, we want to remember that there are 78 million autistic people here in the world who are alive today, and that we know ways to help their lives, to make lives better, but we often do not do it, and we don't know enough. In order to better do this, because there is no one treatment that's going to solve the problems of all autistic people, we need to determine what strategies and interventions support systems and what benefits whom, when, and with what intensity. And those are things that we don't know enough about, even though we know a lot about the tools. This means that we need research on a larger scale. We can't do small-scale studies that just test out one intervention and get the information that we need. So we need help from government and services to find out results that are meaningful on an individual level. And it's a little ironic that in order to get results interpreted on an individual level, we need more results, not smaller. If we can do this, we feel like we can provide better information for the many people around the world who don't get any help at all. And this information can be the beginning, not the end, for culturally appropriate adaptations across the globe that takes into account the strengths of autistic people and their family, but also the incredible needs that go on in different places. Much of this information also has direct bearing on other developmental disorders and mental health conditions. And sometimes we can be so caught up in autism that we forget that there is a lot of overlap with people who have other kinds of issues. Acknowledging the heterogeneity of autism, we need to think about, as we consider interventions, the idea of a stepped care, personalized health approach to autism. And although this builds a bit from the idea of precision medicine and personalized health, it's coming from a very different point of view. So rather than just considering, for example, the genetics or the cost to a hospital system in creating steps, we need to consider what are the needs of the individual, where are they coming from, what are the skills and resources of a particular family, a community, and then where do we go from there? Because autism is not a disease, but a condition that can cause impairments in daily living, but which vary tremendously across individuals. And we need to recognize, again, both the strengths and the needs of those individuals, as well as their families, their communities, and where they're coming from. This is just a quick visual of the idea of stepped care, and just the point that you can see along the left side. We're trying to focus on what are the needs greatest for the family. And there are systems, for example, in Australia that begin to do this. But then the second consideration as you move right is, what are the individual characteristics of this particular child or adult? How old are they? Are there safety issues? Are there sensory issues? How much language does this person have? And then what are the family factors? And these need to be included right from the start. What does the family want? Are they concerned about the acceptance of their child? What are their preferences? And then these should be taken into account as we begin to look at availability of cost. And there are some interventions, for example, that are very cheap and easily accessible, but they may be harder for families in some cases. So as we move from left to right, we want to consider not just the cost to the hospital system, but also the cost to the family. If families, for example, are being asked to carry out the majority of an intervention, can they do this? Do they want to do this? Is this helpful, or is this another burden? Just to give you two examples, this would be a minimally verbal child in a lower or middle class country. And there you might be thinking about their individual needs that are different. Let's go on here. From a child, here. Okay, here we go. This is just, so we would be considering the individual needs. Sorry, I guess I have to keep clicking this button too. That include, for example, this is a young child who doesn't talk yet, who has a lot of behavior problems. His parents may have particular preferences for how he can be treated, and that's where you go, and that's where the steps come in. This would be quite different, say, for a 15-year-old who is highly verbal and very anxious and is in a regular school system. And there, the preferences for the family, the skills that they bring to this, the needs for support, and the 15-year-old who can speak up for himself, all represent different steps in the choices of care. So this means that if we're going to do this right, though, we need to know what interventions work for whom. We need an evidence base that doesn't just say this intervention works, but when does it work and when is it appropriate? And this means that we need personalized knowledge as well in terms of the assessment about the family and the resources in the community that are remotely possible. This means that we need to figure out financially feasible ways of working within and across systems to both support research to answer these questions and then to use this research to implement changes. And many of us live in societies where those things are available, but they are not attached to research yet.
It's raining,
so
I think. Not very nice.
Let me now introduce Brian Boyd, who is a member of our commission and a professor and director of the Juniper Garden Children's Project at University of Kansas, who will talk to us about interventions, services, and systems. Brian?
Thank you, Kathy. I just want to say it was such a privilege to be a part of this group and to work with such a wonderful group of co-authors. And I get to present some key recommendations today around the areas of intervention, services, and systems of care. So the first thing we know is that we do have some evidence-based psychosocial interventions that exist, mostly focused on young autistic children. And this is one of the many figures you can find in the Commission report, but it shows that we have some evidence-based interventions where we see effects across a variety of developmental domains. But we also have to acknowledge that most of this research was conducted in middle and high-income countries with majority white samples. So we do still have the question of evidence for whom. We also have naturalistic interventions to promote positive parent-child interactions that have been successfully implemented in low and middle income countries, right? And the preschool autism communication trial is one example. There's also some general agreement about helpful intervention strategies that a lot of clinicians use to provide effective supports and services to autistic individuals. And we can think of visual supports as one example. Now, they may not have the traditional empirical evidence behind them. You know, they may not have been subjected to randomized controlled trials, but we know they work and we know lots of people use them. The other thing we currently know in terms of thinking about the state of the field, in terms of what we pull from the Commission around interventions, is that psychopharmacological treatments tend to be prescribed later in life. Really, we see them being prescribed in later childhood or adolescence to deal with co-occurring conditions such as anxiety or depression that we see in autism. So that's sort of the current state of the field around interventions and some things you'll find in the commission. So what are some of our current challenges within intervention research? Well, one is that we still are trying to figure out some of our key ingredients of effective interventions. What are the actual mechanisms of change, including biomarkers that help us predict treatment response or understand response to treatment? We still have an issue with scaling up our interventions to ensure they are adopted, implemented well, and sustained in community organizations and systems. As I said before, we have evidence-based psychosocial interventions, but they're largely focused on younger children. So there's still specific subgroups of autistic individuals, in particular adolescents and adults, females is another example, where we need more evidence. We also need to generate more evidence for underserved or under-resourced groups. Do we need more culturally adapted or culturally tailored interventions? And as Kathy said, we still have these questions around which interventions work best, for whom, what's their appropriate intensity, and what's the appropriate developmental timing for those different interventions. And so what were some of the key recommendations related to intervention that came out of the commission? Well, as Kathy showed there on the screen, one of the primary ones is to move towards the step care model, really thinking about more personalized interventions that take into account from the onset the preferences, priorities, and needs of families and autistic individuals, and knowing that there's likely not one intervention that will be useful and effective over a person's lifespan, that will need to adapt and change because priorities, preferences, and needs will change as people grow and develop. The other is that we need to, yes, move our evidence-based practices into organizations and systems to get them sustained. And so we can do that by maybe using what we know from the field of implementation science that really is helping us think about how we use scientifically validated practices to go about that work. The other is we likely need more cost-effectiveness research to help support intervention decision-making. So if an organization or family is trying to make a choice between two effective interventions, could cost research help them help guide that decision, those decisions? The other is that we do need to do more to engage stakeholders and, importantly, autistic individuals in both the development and deployment of our interventions. And as I said, because we still have a lack of evidence base for underserved and under-resourced communities, there's a desperate need to think about more culturally affirming and culturally tailored interventions for certain groups. And the questions around intervention timing and dosage, those are complex questions that the field still needs to answer. So how can we use more advanced research designs, such as adaptive intervention designs, to help answer some of those complex questions that the field is still struggling with? So shifting to service systems from intervention. So what's the current state of the field? What was sort of outlined in the report? Well, one of the important things is that 95% of children under age 5 with developmental disabilities live in low and middle income countries. But many of those children have limited access to services or no access to services. So we need to think about how we improve service systems across the globe. So, and even in high-income countries, many of our existing service systems, right, may not be designed to meet the specific needs of autistic individuals, or they may be underfunded or understaffed. And we know that in high-income countries, and in particular low-income countries, that many individuals experience service deserts, places where they just can't get access to services, much-needed services and supports. And for many families and autistic individuals, once they do begin to receive services, whether they be through education or health, this role of being a service user becomes a lifelong role, one that they have to constantly navigate and figure out. And so how can we improve services knowing that families and autistic individuals are going to be taking on this role that to some degree becomes a part of their identity? And so we know some of our current challenges is that systems aren't very well coordinated, that our funding models don't support care coordination or service integration across various service systems and sectors, that there are many barriers to service access for families, even in high-income countries. For example, the service system where you may go if you have a mental health challenge may be different than the service system you go to if you have a disability. So what if you're an autistic individual who has anxiety, who has depression? Sometimes you get turned away because the service systems are sort of legacy systems, and we need to help people. We need to remove barriers so autistic individuals can better navigate those. And we need to establish effective systems of care that are specific to the local context and needs of low and middle income countries. So what were some of our key recommendations? One, we need service systems that are more responsive and strive for continuous quality improvement, that are using data to guide changes that need to be made based on the changing needs of autistic individuals and their families. That we need to do a better job of integrating the evidence base that we have, the evidence-based interventions that we know to be effective, into our service delivery systems. That we need more high-quality research conducted in low and middle-income countries so that we can address the science and services gaps that are specific to those countries, and those so that we can set up systems and services that meets the needs of those individuals living in those countries. And importantly, we need to ensure equitable access across the globe. We need to make sure that people are getting access to the services and the supports they need. And we know that this is an issue in particular for underserved and minoritized groups. I think the final thing a couple of final things I wanted to touch on is one related to schools. So schools often are really a source of intervention and support for autistic individuals of a particular age. But even in some high-income countries, our current challenge is that although schools have to serve students with disabilities, a number of them are underfunded or experience personnel shortages, a high degree of turnover. There's issues with training of personnel and all the different evidence-based practices so they know what to do. And low and middle income countries, schools may not be able to provide the specialized supports that autistic students need or other students with disabilities, or only provide services in segregated classrooms. So there isn't an opportunity for autistic students or other students with disabilities to be included with their peers, their neurotypical peers. And so there's a need to ensure that autistic children across the globe get access to a high-quality education in schools, because we know it can be a source of intervention and supports for large numbers of students. We also need to make sure that there's funding for school-based research and service delivery in that context. And finally, just to speak to workforce capacity, went too quickly there. We know that in both high-income countries and low and middle-income countries, it is often non-professionals or those without professional training who are heavily involved in the care of autistic individuals. But there's, in particular in high-income countries, there can be some challenge related to actually being able to pay non-professionals, those who don't have the qualifications or credentials needed to offer for their services that they're providing to autistic individuals. So we talked about task sharing as a way to build workforce capacity so that tasks are distributed across those who are professionals and non-professionals. But it's not only a way to distribute tasks, task sharing is also a way to build workforce diversity. And I think that's also a critical and important point. So with that, I will now turn it over to Tony Sharman, who is a commission co-chair and also a professor in clinical child psychology at King's College London. Thank you.
Thank you, Brian. Hello, everyone. It's a pleasure to be here. Kathy and Richard and Brian have thanked many people, and the person I want to thank a lot also, amongst everyone who's been mentioned, is Kathy, who has led this commission from the very beginning by inviting us to join her in the effort So I'm going to be talking about some of the complexities of our current understanding of autism and how that's guided us in this commission to think about how we can make recommendations about things that need to be done and that need to be done and prioritized in the next 5 years. And I'm going to be talking a little bit over some of the same territory as Kathy and Brian, but also talking a little bit about the concept that Richard has mentioned that we've introduced in this Commission report about profound autism, and talking about what's needed in terms of research funding and what governments can be doing and should be doing to help make that difference happen. So we use the word, and it's a complex word, autism's a heterogeneous condition, so that also many people use the term autism's a spectrum condition. That means that autism manifests differently between different individuals. Some autistic people can live independent lives and be very successful in the societies that they live within. Others need support every day throughout their lives, and many, many others fall in between the two. We also know for every individual autistic person, the way in which their autism is affecting them and manifests itself is going to change across their lifespan. It's a developmental condition, and that, as Brian and Kathy have said, autistic people will require different interventions and supports at different points in their lives. I'll come on the next slide to talk about the description we've given of something that we think deserves a separate sort of description in terms of profound autism. But at the same time, we've emphasised throughout the sort of commission that it's many autistic people have strengths, significant strengths that contribute to their family, community and society. Like all of us, autistic people have different profiles of strengths and needs, but there are some perhaps aspects of the autistic way of thinking and the way of processing the world that means that they're able to focus on particular areas of interest. And some people can gain very highly specialized knowledge or skills, or see things in a different way, see the world in a different way that that ends up being very creative. Also, sometimes autistic people have a different take than neurotypical sort of people on the interactions that they experience from interacting with other people, perhaps because they're sort of less wedded to sort of social norms. And we used the phrase at one point that I think, considering autistic people can hold up a mirror to the rest of society, that we can sort of learn from. So we feel that, and we emphasize in the report, that recognition of human neurodiversity helps us to better understand autistic individuals, however their autism manifests, and that can help us create stronger and wiser communities and bring positive social values for us all. We have a section, a panel, a call-out panel in the Commission on the concept of sort of profound autism, and we are mostly sort of thinking of this really as a sort of administrative sort of label, which we think will be helpful within services. And here we're referring to autistic individuals who have severe intellectual or communication disabilities, often both intellectual and communication difficulties. They have profound needs for care and support. They by definition, are not able to speak for themselves. They often will need extensive care right throughout their lives into adult life and further on. They need to have a responsible adult who can look after them in the vicinity in which they're living if concerns arise, and often they're not able to take care of basic adaptive daily functional needs. Many of those individuals with autism and intellectual disability and very limited language or communication skills, in this description of individuals with profound autism that we use in the Commission, will have very complex and often quite impairing and sometimes quite disturbing co-occurring difficulties They can be showing a lot of self-injury. They may have organic medical conditions such as epilepsy, and their behavior can be very challenging. We think that the research evidence shows that this can be identified in a reliable way that's going to tell you something about adult outcomes from mid-childhood, when the future sort of likely needs of that autistic individual become clear. Not showing you any of this, but we have done some additional novel data analysis on 2 population cohorts, one from Norway and one from the UK, and a clinical cohort from Kathy Lord's lab in the US. And in those cohorts, depending on exactly what the definition is, somewhere between 18 to 48% of individuals meet the criteria that we're proposing for this. What we hope is that introducing this term will do 2 things. We hope it will spur the research and clinical communities, and indeed funders and governments, as Richard said, to prioritise the needs of this vulnerable, highly vulnerable, and very underserved group of autistic individuals. We also think it will enable families to advocate for the care and support that their autistic children need. This is just one of the sort of graphics that's just showing you the developmental approach that we've sort of taken, and the sort of interdisciplinary sort of approach that we think the science of autism sort of tells us about. We know that autism is fundamentally a condition of brain development and differences in brain development and functioning. Many of those differences have a genetic origin, but there'll also be early influences on development, mostly prenatally, very likely, environmental influences on that as well. But once an individual with autism is born, then there are all sorts of other things that influence what their outcomes in different domains of functioning and different domains of life, whatever the context and setting and society and systems that they are growing up in. We know that many individuals with autism will have co-occurring mental health and sometimes behavioral difficulties, as well as high rates of some sorts of medical problems and other sorts of things. We know that many individuals with autism will have unhappy experiences, sometimes in the education system, and not always succeed at school. From what Brian and Kathy has said, we know quite a lot, and we can do more to know more about the difference to life outcomes in education, independence, and quality of life that those environmental influences can have over someone's sort of life course. And that's the developmental scope, you know, that we think is sort of possible, and what we try and lay out in the sort of commission. Autism is a neurobiological condition, and basic science, translational science, is important. We've chosen not to focus on that in the commission. We recognise its potential value in future because we felt the important need to focus on things that can make a difference now and in the next 5 years. So we are mostly talking about research that needs to be done and changes to clinical practice that can be put into place now or in the next 5 years. So we're talking about targeted research that can improve mental and physical health outcomes, strengthening support systems to enable all individuals with autism, however it manifests across the spectrum, to have improved outcomes that will improve the quality and experience of life, both for autistic people and for their families, who are often their lifelong partners involved in their care. And I'll come back to thinking about the research priorities, you know, in my last slide in a moment. So here's another sort of graphic showing some of the same things where really, you know, change is possible. Interventions and system changes can affect development and make a difference to outcomes. The different manifestations, the heterogeneity of autism can make that challenging, which is linking back to what Kathy said about the need for this new model of care where we have this personalized stepped care approach to thinking about the profile of needs and strengths and preferences and the setting and the developmental time points, and making sure that we get all of those things sort of right, as well as Brian emphasized, making sure that the recommendations are appropriate to the society and the culture in which that autistic individual and their family live. So our message is that change is possible, that much can be done and should be done to enable all autistic people to reach their potential, and as we say in the report, to lead happy and fulfilling lives wherever they live across the globe. And then these are messages that we have in the report on recommendations for governments and research funders. So one thing we think is important, this happens in few countries and could happen and should happen and can happen in many more, is there should be some formal documentation through governmental systems such as healthcare, education, social care systems that would help determine the needs and address the potential inequalities faced by autistic people wherever they live. Governments and healthcare systems, as Brian was saying, they need to recognise the need for integration across systems to better support the needs of autistic people and their families across the developmental lifespan wherever they live. And focused research strategies should be prioritised in the way that Brian's been emphasising, with an emphasis on clinical practice that can increase the understanding of what works, for whom, when, how, and with what general outcomes and at what cost. One thing that we also highlight is, throughout the Commission, is the fact that there are we have several calls for sort of social equity and social justice. Governments and services not only should be documenting how individuals with autism are navigating the systems that they are experiencing in those societies, but they need to make sure that some of those individuals from underserved groups, those with profound autism, girls and women, minority ethnic groups, groups from socially disadvantaged backgrounds in different cultures, or those with the most severe co-occurring conditions, have equitable access to appropriate services and do not remain underserved and disadvantaged. And then I'm handing back to Kathy.
Thank you, Tony. So I get to end up, and I just want to say and reiterate that this is a message of hope. And the slide, the figure on the left just shows the idea is that as there are more opportunities, as you move from left to right from the different boxes, the abilities of different people with autism, both those who have very severe adaptive problems, but also people who really have the potential to do many, many things. Everyone is more able to manifest their actual potential for change. We do feel like there are many, many things we could do now, and there are many things that we need to know that would not take an extraordinary amount of time to find out, but would take coordination across different systems and recognition that there is no one answer. So our overall point is just that we really need to work together as providers, families, people with autism, to get things done now that will make a difference. So thank you very much, everybody. And I'm now going to introduce Mary Barua, who is the first member of our panel, who is the head of Action for Autism, the National Center for Autism in India, and a long-standing advocate. So Mary, take it away.
Thank you, Kathy. Hi, everyone. Thank you very much for inviting me to speak at this amazing launch of an amazing piece of work. It's a privilege to be among such distinguished speakers. I am primarily a practitioner, not an academic or a researcher. I have friends and colleagues who are autistic, and my son too is autistic. He has what the Commission terms as having profound autism. I also come from a country that has 13 million of the 78 million autistic people in the world. I think it's great that the Commission has come up with the term profound autism as an administrative term, because I think it's far more meaningful and does not have the baggage of severe or low functioning, which is actually quite misleading given the spectrum of skills and challenges that autistic people have. In India, we use the current term that we use is people requiring high support. So there are people, those who have high support needs and those who have low support needs. One of the thoughts I had when reading the report was that, one of the markers that has been mentioned is living independently. And given that, we are talking about LMICs and HICs, there's a vast diversity, and living independently can be a fairly subjective term because it depends on the accommodations that society provides. For instance, in societies like ours at an earlier time, and to an extent even now, in older, what we call joint family systems, there were accommodations that were built in, and people with autism would be living there, and they would be living independently because a lot of their needs were taken care of. And some developed nations provide accommodations that foster independence, such as structure, social services that come around and check on people. But countries that are kind of in between the older systems, for instance, as is happening currently in India, where the systems are giving way to extensive urbanization, the support systems are not in place, and independent living is impossible for some who would otherwise have been living independently if they were living in a country where the support systems were there. So some of these things would vary a lot from country to country, and there would be differences, of course. The other thing is that I was really glad on reading the paper to see that the focus is greatly on interventions rather than on finding the cause and the cure, because too much of research has gone on causes rather than measures to improve the lives of autistic folks and their families. And also because any biological treatment that is found can only serve a very small population. And sometimes it seems that this fascination with finding a cure for autism is because autistic people look so typical, even though their neurology is so different and their brains work differently. And the focus of our work at Action for Autism has been on the happiness and well-being of autistic people, and equally important for the families, that they can be happy and accepting of the autistic members. And in our work, we view autism as a different way of being. And therefore, reading the report and seeing the importance of valuing diversity being mentioned there felt extremely heartening, because very often research papers do not talk so much about the diversity and the importance of acknowledging diversity, because that moves away from insisting that autistic people must act normal, because intervention very often is all about making them act like neurotypical people, and we do not have those expectations of other developmental conditions, like, say, somebody who has cerebral palsy, or even somebody, say, who's blind. We do not expect the blind person to start acting as a seeing person. But the focus of most intervention for autism continues on making the autistic person act non-autistic. And if we do not value the person, we may teach them a lot of skills, but we will not really be able to help them reach their full potential, because nobody really can if the focus constantly is helping them feel that they are not good enough, and they begin to feel that I must become someone else in order to be valued. So we often see youngsters who are struggling because this is the message that they receive all their lives. And as a result of this, we often see that their identity takes a blow because they're constantly hearing how faulty they are. The other thing that is often suggested is that being neurodiverse is equal to not requiring intervention, and they're not really mutually exclusive, because everybody, even neurotypical people, require intervention in a lot of things, because nobody is perfect. And I think what is important, and what really the report is bringing out, is that we have to provide a meeting halfway where we understand autism and help the autistic people understand the neurotypical world, and provide the accommodations that autistic people require in order to function in a world that is not really created for them, and be what we often term as being cross-cultural interpreters. And I think that is really something that the report is bringing out, and that feels really good. And it is very, very important to bring in interventions, to bring an autistic perspective, because like I said, very often it is on reduction of manifestations, or, for instance, it often talks about, interventions talk about how autistic people have poor motivation. But if we look at the autistic perspective, it is really our perspective, the neurotypical perspective, that says that they have poor motivation. They are motivated. They have their own motivations, which are different from our motivations. Or when we talk about anxiety and depression, we have to understand it from their perspective, because a lot of the anxiety that autistic people feel is because they do not have the predictability that they need. And we often, as practitioners, I know that I've done it, we try to break their routines. And that is why they often end up having meltdowns. And if we make the world predictable and we try to understand the reason behind their routines, if we make the accommodations for autistic people that we would for people with other conditions, there would be far less anxiety and depression that many of them suffer from. So when we're looking at this wonderful stepped care personalized approach that the paper talks about, I think it'll be very, very important to perhaps focus a little bit on something that Brian mentioned, on the use of structure and visuals and AACs, which are the accommodations that autistic people require, just the way people who are blind require, for instance, Braille or some kind of, apps or computers or textured pathways, which are the accommodations that they need to function. The other thing about the family intervention, it would be great to focus on not just helping families be able to teach their children better and keep telling them that there must be better outcome, because sometimes they may not be great outcome and you can still be happy. There are autistic people who don't have great outcomes, families who have children who don't have great outcomes. But there is acceptance and happiness, and that is something that I think it would be great to focus on a bit more. In fact, we have been running a family-centered training amongst a lot of other things that we do for many years, about 20 years now. And one of the focus of that is empowering families towards acceptance, because we find that that is one of the things that really helps them help their children. So whatever we do, it is great if it can be based on an understanding of the autistic experience. For instance, one of the things that struck me was, when there is parent-reported hyperactivity, we often think of it as an, ADHD perhaps, but it could be an indication of a sensory need in a child rather than just a hyperactivity disorder. It could be a sign of confusion because of a sudden change perhaps that has happened. So these are some of the things that occurred to me when reading the paper. And there was the mention of moving from the medical to the social model, and I think that is really what the paper is trying to do, and that is so important, to move from the medical to the social and the rights model of disability. And with that, I'll turn it over to Sarah Spence, co-director, Autism Spectrum Center, Boston Children's Hospital, USA. Thank you.
Thanks, Mary. I really appreciate that. I will echo many of the things that Mary talked about. I am also a clinician, albeit I do have a research background. I also am an administrator of a large academic autism center in one of those high resourced countries. And as in my role, I will really suggest to everyone that they sit down and read this commission. It's really, the work is amazing. I'm supposed to be an expert in this area, and I learned so much as I was reading it. I was especially pleased to see a number of, what I would kind of consider truths that I've always felt in my clinical work and sometimes in my research work. But here it was documented beautifully in this commission report. So I think I mean, I can discuss a few of those just for people who haven't actually looked at it yet. One of the things that we heard a lot about was that the criteria for entering early intervention, if these were changed from requiring an established diagnosis to something that was maybe possible or probable autism, we could get a lot of kids into service earlier. So you heard a little bit in the introduction about the idea of not focusing just on disorder-specific assessments. There was a great discussion about transitions and the fact that those are quite difficult. And I work at a children's hospital. I'm a pediatric neurologist, but I have patients in their 30s and 40s in my practice because there really aren't enough trained adult providers. There was a lot of discussion about the fact that most patients or people with autism or autistic people are actually adults now, and we have very little knowledge about adult health outcomes. It just hasn't been a focus of research, and that's something that has to change. We heard about the heterogeneity of both autistic people, but also of their families, of the cultures they live in, of community resources. And that means, there's no single treatment plan, there's no single intervention that's effective for all or even needed for all individuals. And so that's the incredible importance of this personalized approach. I think the other thing that people talked about was, again, given the heterogeneity, what works now might not work later for the same person, and what works later might not work now. So this lifetime approach and really looking personalized, individualized, finding out what's working at the time. I think the other thing that we heard about and Tony talked about really beautifully, the idea of the importance of neurodiversity. I mean, this is a concept that's hugely helpful. It's hugely important, but the Commission talks about the fact that it's sometimes controversial. And certainly as a provider, I have seen families on both sides of this coin where there are people who talk about the fact that this is a gift, and neurodiversity is a gift, and everyone should be thinking about it this way. And then you have families with those children who are now, as we talk about, as the Commission talks about, described as profoundly autistic, with many, many impairments. And I think that there are people who don't think of this as a gift. They don't think of this as a good thing in their child's life, in their family's life. And I think one of the things that we could do better quickly is how do we share ideas between the both sides of this coin? And so I think that's something in the focus of the Commission of doing things in the next 5 years. This is something that probably could get done relatively quickly. I think the other thing that really struck me, and this was the point of being invited to comment on the Commission, I think we all in the panel feel this way, is we were asked to really look at this according to how it impacts our careers, our lives, maybe our families' lives if we have a family member with autism. And I think they talked a little bit about co-occurring conditions and the fact that these are very common, and often that they're as important an issue for the autistic individuals and their families as the autism itself. And that rang so true to me as a clinician. I'm a neurologist. I take care of individuals with epilepsy. This is something that happens in a minority, but not a small minority of autistic individuals. And I'll tell you that there are families who have handled all the challenge of autism up through age 18, and then the first seizure comes in that late adolescence or early adult period, which is sometimes when seizures happen. And it has been extremely difficult. And I've had families who say, I can't handle this. And I have to say, of course you can. You've been living with lots of challenges your whole life. You've been doing an incredible job taking care of your child, and you can handle this. This is okay. But it feels to them like it's the end of the world. So I think the understanding of the co-occurring conditions is very important. And again, in terms of thinking, what can we get done in the next 5 years? This seems like an educational issue to me, the idea of sharing across disciplines. And one of the things that I've found in kind of 20 years of working with the autistic population is, especially in the research domains, we're often quite siloed. And so sharing across disciplines, maybe the neurologists are only taking care of the epilepsy, the psychologists are only taking care of the behavior. And of course, epilepsy affects behavior, and behavior and, say, sleep problems can affect epilepsy. So I think this idea of sharing across disciplines so that everyone can take a personalized approach. The other thing I wanted to bring up is just, what do we do about the lack of data for adults? I think that's a huge issue. Is this something that we could push on the agenda in the next 5 years, where we're looking at these larger samples? Is there a way to identify the adults and really collect some data quickly so that we can make more impact? We all know how much impact has been made for young children. I think the other question I would have is, how do we actually get to a place where the disorder-specific diagnosis is not necessary to access services? Because at least where I work in the state of Massachusetts, you need to get an autism diagnosis in order to actually access a lot of different behavioral services, even though we know, and the Commission so beautifully put this is not something that we should require, because these kinds of interventions actually work very well on a lot of different places. I think the other question I had is if this is going to happen in 5 years, we really need good outcome measures. We need kind of easy data collection. As Kathy pointed out, we can't keep doing these very small trials that are very intensive and very costly. So we need these larger samples. We need funding for this. And obviously we need measures of fidelity. So I'm just going to finish by saying that there are things that I'm going to take away, and I would hope that as other people read this document, that there are ones that they are going to take away as well. The concept of potential for change is so important, and the Commission actually recommends that this needs to be documented. And I have to say, I think I'm a pretty good clinician, but often I'm focused more. I had a clinic this morning. I was focused more on the problems that are being faced by the family during that clinic visit than really documenting the improvements. And this is something I'm going to change as a result of looking at this Commission. Everybody has talked about the importance of this, knowing kind of who, what, when, and where, right, and for how long. That is just incredibly important, and I think can't be overstated. I also feel that the personalized care model is going to help addressing the important co-occurring conditions that we've discussed. The importance of patient and family advocacy and kind of how we might be able to harness this to improve care. I would say this is true both in involving parents in interventions in this stepwise approach. We talked about cost analysis, but also in terms of policy level. There's a beautiful section of the document that talks about all of the parent kind of led policy changes that have been done all over the world. And I think we can't forget that, and we can't underestimate the importance of that. The huge problem that outside areas, in urban areas in most countries, families really have no virtual access, or virtually no access to either assessments or evidence-based interventions, and this just needs to be changed. So the ideas of building capacity in low and middle resource income countries, and for those with less access, even in high resource income countries. Finally, I'm just going to comment on the profound autism concept. I think it's extremely important. It was one of those things, I was actually on the DSM committee when we re-termed autism in 2013, and our severity measures, I think, I'm speaking only for myself here, but I think it was the weakest thing we did. And so I think there is a need for this. And while it may be hard to operationalize logistically, it's an incredibly worthwhile topic. And I think something that many clinicians and researchers would be interested in getting involved with. So again, I thank the Commission for letting me read it a little bit early. It was fabulous to read, and I encourage everyone else to read it too. I'm going to turn this over to the next panelist, Angelina Kakuza, who's Associate Professor of Pediatrics and Child Health at Makerere College of Health Sciences in Uganda.
Thank you very much, Sarah, for the introduction. And good morning, good afternoon, wherever you are, from whichever part of the world. I want to take this opportunity to thank Catherine Lord and Tony Charman and their colleagues for putting up this commission report on autism, and also for inviting me to share some perspectives as a clinician and academician working in a low and middle resource country, Uganda. I read this commission report much earlier, and I had the honor of writing a commentary for the Lancet together with other colleagues. But regarding the issues that were quite relevant for me as a clinician and someone practicing in a low and middle resource, I can say a lower resource setting, are 4 issues which are quite relevant to my day-to-day practice. The proposed evidence-based stepped approach regarding use of multiple providers is something that is very, very important for us, because we are in a situation where we are hampered by lack of human resource. We have very few specialists, and people that are at the tertiary level who take care of these patients are very, very few. So if we have this personalized stepped approach, it's going to mean that each patient or each individual whom we suspect probably has any developmental delay or has any disturbance behavior is going to be assessed at that level with whichever provider is there. They're going to, together with the family, be able to come up with what is feasible at that point in time. In the past, there was so much emphasis on you need to get this tool to be able to diagnose this condition. But now we are moving away from that, and not so much on a categorical diagnosis, but on the functional deficit. What is it that this child has at this point in time that is going to help this child? So by having this personalized step approach, it's really going to be very helpful in terms of reducing pressure, in terms of caring for these people. So right at the grassroots level, at the primary healthcare level, these patients will be able to get care at least at the beginning. And thereafter, depending on whatever else they'll need, they'll be able to access care gradually. Another issue was the need for training non-specialists. And of course, that works together with what I've just talked about, the personalized stepped approach, because we know that the burden of the care for these patients, especially the profound autism, depends so much on the family. Because of the stigma and discrimination that these patients face, they're most of the times hidden at home. They don't come out because of what are people going to say about us? How do I handle this? This is a curse, or this is a demon-possessed child. So these children are hidden. So the care and burden really depends on the family, right at their homes. If we have this personalized stepped care approach, and we're having these non-specialists or even caregivers who are really empowered to take care of these individuals, it's going to go a long way in trying to care for these individuals who are really not having access to care, and now having this opportunity to have these empowered caregivers or non-specialists who can at least give them a feasible approach to care for whatever they have. And what is important is that in doing all this, there's going to be improvement, not only on the autism aspect, but also on the other neurodevelopmental problems or conditions that the child may have. This is going to cut across and help in identifying probably the child has epilepsy, probably the child has a speech and language problem, whatever it is going to be, is going to really help in terms of caring in that way. So this emphasis is very important, and the integration helps to ensure that this is sustained across the child's care and across the child's lifespan as the child grows. Now, regarding some issues that I felt the Commission could talk more about is the education aspect. We know that in the lower resource settings, there is, of course, a push to have inclusive education. But many of these teachers are ignorant in terms of, maybe to say it in a better way, don't lack the skills in terms of how to care for a child with a neurodevelopmental condition. Some are even stigmatized and don't want to have such children in their classes. So having a situation where you're having teachers fearing these children to educate them, not even knowing how to care for them, we need to come up with a way in which we can engage teachers, engage the community to understand what it is. These attitudes that the teachers may be having, and also that the community may be having in terms of educating these children, has got to be cleared by having a community engagement between these two parties or all the stakeholders involved to ensure that you come up with a curriculum that is pertinent for caring for these children, and also having ways that you can equip the teachers with skills on how to manage these children. I can talk for my country. We are signatory to the Convention on Children with Disabilities. We say, yes, we actually are promoting inclusive education, but the reality is that many of these schools are not equipped. They'll put these children in a class, but the children just play from morning up to evening. Nothing is given to them in terms of trying to help them get the skills that they need. So what is put in policy is not really translated into practice. And that is one of the biggest issues that I see in the lower resource. We go on ahead and say, yes, we're signatory to this, we've ratified this policy or this convention, but in reality, what is on the ground is not what is on paper. Then the issue of awareness. There's a very, very big issue regarding awareness, regarding autism, especially in the lower resource settings. You find that people can view a child with autism as, well, this child is a gift for us, so we shouldn't do anything regarding the care. If we tamper with anything, we're tampering with our gift. So let it be as is, and we leave this child. So we need to raise awareness for them to understand that this child actually has potential and needs to be cared for in a way that is pertinent. Then there are also issues regarding transition. We know that many of these children grow, but where do they go? What happens to them? We never find out because there is no research in terms of what happens from transition from childhood to adulthood. Are these people recognized by their countries? Are they given employment? So those are issues that we really need to cater in terms of their human rights, their access, their equity, and their participation in normal day-to-day life. These recommendations or these issues that I'm discussing are also in line with what Catherine Lord, Tony Chairman, and colleagues wrote in their report. And they focus on the recommendations that deal with culturally adapted and tailored intervention approach, cost-effectiveness research and the need to support decision-making, and having governments and other stakeholders be involved to ensure that in a stepwise way, we're not going to just work alone as clinicians or academicians. We need to have all the people that are important, stakeholders, civil society, government, religious leaders, and all sorts of people that are involved in these caregivers, to be involved in the care for these patients. And I'm sure that by ensuring that all these people are on board, we will promote awareness, we will ensure that there is equity, we'll ensure that their rights are actually addressed, and also in so doing that the potential of these children who are very much neglected, especially in the lower resource setting, are realized. I want to thank Catherine Lord and Tony Chairman and colleagues for having invited me to participate in this webinar. And I'm sure that all of you who will read this article will realize that it's a way in terms of our next 5 years as a way to move forward. Thank you very much for your attention. I'll stop here and introduce Kat Hughes, who's the Research Communication Manager, Autistica. Thank you very much.
Thank you so much, Angelina, and thank you to the Commission for giving me the report to read ahead of time and having me here to speak on it a little bit. Part of my job at Autistica is to communicate the experiences of the autism community, and then also I'm one of the 78 million, so I have an autism diagnosis that I got about 12 years ago now. And for me, then, my relationship with autism and with this report is a very practical one. And that's something that really stood out to me in the report, is how practical the focus is. I think historically, as Mary said, the way that research has looked at autism has been very much to sort of try and understand the nature of autism, causes and cures. And I think from an autistic perspective and from a family perspective, that oftentimes isn't very practical or useful. If you know, I'm feeling overloaded with anxiety and have a difficult time leaving the house, or if a parent just wants to support their child who's having a really difficult time in school, you want that practical, tangible support. So I think it's really laudable that that's in place in this report. From a UK perspective, we know that that's what the community is really interested in. Autistica have commissioned a piece of research where we've asked what the community priorities are, and we know it's those sorts of things like anxiety and psychoeducation and employment. So there are also things, as Tony said, that can potentially be implemented relatively quickly, and then on the back of that, the impact felt can also be equally quick. So I think it's really important to have that practical focus. I think having that focus on the daily living kind of lends itself really nicely to the personalized approach that's also included in the report. Tony spoke on the changing needs that a person might have throughout their life, you know, as they age or as different sort of support systems are available to them. And then equally, there can be different support needs across the community. And I think the report does a really nice job of using the neurodiversity paradigm to explain those different sort of strengths and needs that a person and the community have. And I think there can be, as Sarah said, sort of a wariness around neurodiversity and talking about neurodiversity, because people can feel that, you know, a portion of the community isn't represented and their experiences aren't heard in the way that they should be. But I think what this report shows really nicely is that it can neurodiversity focuses on sort of individual experience, and that individual experience is incredibly valid, and it's about meeting the person where they're at in the moment and figuring out what the supports are to help them to thrive in whatever way it may be, and whatever way that makes them happiest and healthiest. And so I think that's that sort of individualized stepped care approach is probably our best bet for achieving those supports that people need and that sort of healthy, happy life. As Sarah said as well, I was really delighted to see co-occurring conditions mentioned in there. I think the idea that, you know, as someone gets a diagnosis, or if they're on the path to diagnosis, then that also is a path to the other diagnoses that they may need in their life is a really positive step. One thing I would love to see is kind of joined up thinking in relation to that on the other side of services. From my own perspective, I got my first diagnosis when I was 12, and then from sort of 12 to 16, I got a rake of diagnoses of co-occurring conditions, all of which are mentioned in the report as being very common in autism. But it was about 19 years before I actually got my official autism diagnosis. And there were so many opportunities along the way there where autism could have been diagnosed and they could have been spotted, and I could have had those supports far earlier on, and it would have made a massive difference. So I think that's something that I would love to see coming from this report, is sort of to join up that thinking, and whether it's that clinicians have an opportunity to sort of skill up and learn more about autism to be able to potentially flag and direct to services, or whether it's that the actual services themselves can be adapted to become more autism friendly, and sort of procedures and even physical spaces like waiting rooms can be more comfortable for autistic people, because we know whether diagnosed or undiagnosed, there will be a lot of autistic people passing through those services for co-occurring conditions. I really appreciated the personalised approach in terms of looking at the different life stages and the different supports needed at different times. As Sarah mentioned, in relation to sort of those transitions, I think it's really important that we take a step back and think about when we might expect those sort of stepped care interventions to be necessary. And I think we tend to focus an awful lot on early life, so school, puberty, potentially going to university, and then if you're very lucky, there might be some sort of work around employment and sort of early stages of employment. But I think it would be really helpful to kind of broaden out how we look at transitions across the lifespan. So to think of things like pregnancy or menopause, or literal transition in terms of gender, or death of a caregiver in relation to sort of older autistic people. And I think that would give us an opportunity to kind of bring in a lot of the people and community members who maybe haven't been as included in research. And I think that this report will act as a really great piece of guidance in terms of sort of thinking about how we can reach out to those marginalised communities and better develop the supports that are needed. So thank you so much for giving me a chance to have a read of it and talk on it this evening.
So thank you so much, excuse me, to our panelists. You guys, we really just drafted you into this, and you have done such an amazing job. It makes me almost want to start over and incorporate the things that you have said to make it even better, although holy smoke, you guys, that would be a lot. I also want to remind people that you saw 3 of us from this commission, but there are another 29 people out there who did a great deal of work. And I want to keep reminding people that this was very much a group effort. But panelists, you were phenomenal, and also my colleagues, Tony and Brian. We now have a chance for a few questions. So I'm going to just jump in here. I think the first question, and maybe this, let's see, who, maybe, well, Tony or Brian, or anyone actually in the panel, because you guys did read this. The first question was, are we supposed to change the way autistic people behave? And I think this came up a little bit, but I think this was something that the group felt very strongly about. So Tony or Brian or anybody want to respond to this question from someone in the audience?
Well, let me start off, and Brian or others may want to sort of chip in. And this is something that that Mary also sort of talked about, and we know it's a sort of common thread. I mean, I think one of the challenges is sort of what we're thinking about sort of changing, and one of the reasons that we wanted to emphasize that sort of the diversity in neurodiversity means that we need to think about needs of all autistic individuals, whatever those needs are. And there are some individuals with autism, who have, intellectual impairment, who might have a lot of self-injurious behavior, who have no functional communication skills. There are things for that individual that they probably, that it is going to be important that they have the opportunity to change and develop more adaptive and less self-harming ways of doing the things that they will want as an individual, whatever their level of communication sort of skill is. I don't think that means that you're necessarily making that individual more neurotypical. You're not taking the autism out of them. Autism can have secondary consequences that just are very life-limiting, for some sort of individuals. So I don't think it's so much about changing sort of autism as making sure that every individual, whatever their profile of strengths and needs, and the challenges that often come with those quite significant needs for many individuals, whether that be anxiety, limited communication skill, or finding environments very challenging, that you give them the opportunity to learn and be as independent and to be able to make the choices that they want to. I don't see that as changing the person. I think that's sort of part of, well, I hope that, others may not agree, but, I think that's sort of part of it. I don't see those views as being necessarily in conflict. I think you're giving opportunities to the autistic person and helping and supporting their families, not trying to fundamentally change them. I think it's a different narrative.
I don't know, Kat, do you want to comment? Or Brian? Sorry.
I know, and I'll be quick. I think, Kathy, really, I think what Tony says is actually quite correct. But when we were talking about change as possible, I think part of what we are saying is that there's always probably some effective support that can be put into place to help an autistic individual live a happier and healthier life. But how we go about identifying that support may need to be personalized, right, to the priorities and preferences of that individual or the family. So that's where the change is possible. How do we change the environment? How do we help people live happier and healthier lives?
Kat,
if I could just sort of
add anything?
If I could just hop in, I suppose my reading of change is possible is that it's what the individual wants. The focus is very much on the individual happiness. So it's not limiting expectations for the individual and allowing them the freedom to follow the possibility that they might have and develop supports that are specific to them to reach the outcomes that they want. So yeah, I don't think it's about changing the individual or in any way making them less autistic, because I certainly would not want to be less autistic, but there are things that I have wanted support on, and in the future I will want support on. So it's about sort of having the availability of those sorts of supports, I think.
Another question is, why did we choose the term personalized for the approach? And the question is, I think it's partly that we didn't use precision medicine, but personalized medicine is often confused with precision medicine. And I think the question there is, why not person-centered or inclusive? I think I'll just answer this if you guys don't mind. But I think the problem in the U.S., at least, person-centered tends to mean, well, it tends to be very focused on that person And we really wanted to move beyond that. I mean, we wanted to recognize that it's not just the person, but it's the person in a family, in a community. And so we want to personalize what we're doing in the sense of taking into account what the person needs. So that is person-centered, but it's also more than just an individual. And particularly for younger kids, the reality is what they're going to get and what they need is going to be highly dependent on what their families can get them to, or what their families are interested in. As they grow older, it becomes more and more a matter for some people, for some adults certainly, of their personal choice. But it's, I think person-centered has connotations that we didn't want, which is just that it's all focused on that person, making them better, whereas also we want to personalize how we use the community, how we use resources to support that person. So I don't know if that's a coherent enough explanation. Anybody else want to jump in for that one? Okay, let's see. There are a number of specific questions about how would we actually carry out interventions or carry out diagnostic assessments. I think that's probably too specific for us to go into, but I think there is in the actual report a little bit more guidance. This is not a how-to manual, unfortunately. It's really guidelines for people to think about. I think there's another comment, again, about the very high incidence of autism that the CDC just reported now, 1 out of 44, and the need to educate the society about autistic kids and adults. And I think that is really true. And then I think there are a number of comments about the infrastructure for service provision and the fact that it really often doesn't at all match what people really need. I don't know if Tony or Brian, you would want to respond to that, or also Sarah, just as a clinician dealing with the infrastructure. What can we do to make the infrastructure better for autism? And also in lower middle-class countries, I mean, there often even isn't the infrastructure, or as Angelina pointed out, it's listed in a policy, but it doesn't actually take place. Sorry, that wasn't very specific. Tony, will you comment about this? And then maybe Sarah and Angelina?
Well, I saw the question. It was from Ian Mail here in the UK, you know, it's a challenge even in a high-income country like in the UK. You know, when I first saw the comment when you wrote it in, what I was sort of thinking was, I was thinking back, you know, I started, you know, in both clinical practice and research slightly more than 30 years ago, you know, you know, autism was seen as such a rare condition. Most parts of the south of England, where I live and work, and in London, where I've lived and worked all my life, you know, didn't have autism services. Now every local, you know, health organization, you know, will have a provision for autism, or, you know, is mandated to have a provision for, you know, for deals at least with some of the individuals who live in that community sort of with autism. And then every local community will have some provision for in education, sort of, you know, in schools. They may not be special schools, but they'll have bases in mainstream schools for kids who have got autism. That's just standard, you know, but that did not exist 30 years ago. And, you know, autism is a common condition. It does mean that the scaling up and the funding is going to need to be available. That does not happen overnight, and it is a sort of challenge. And I think there's, you know, a little bit what people were talking about in some of the other comments, and you've just addressed, Kathy. There's the education and the raising of awareness in the public. There's empowering autistic individuals and family members to bring the needs of their needs, you know, as individuals and as a family, you know, to governments and sort of politicians. And then there's research funders and researchers. We need to be smarter to make sure that we actually do provide evidence of things that can bring benefit and know how much they're going to sort of cost. So people are absolutely right. It is a challenge, and services in low and middle income countries, the gap is larger. The gap to be bridged, I'm sure, I know is larger, but it is a gap that we'll need bridging, because autism is not going to change and go away. And many of the needs we've highlighted right across the spectrum are ones that people will continue to have into the future. It is a challenge how common autism is, for sure. But as you said, and we said in the report, many of the solutions and the approaches to the solutions apply much more widely to broader neurodevelopmental conditions and mental health. So some of the things we're talking about are not specific just to autistic individuals, but to all individuals who have that kind of challenge.
Anybody want to add anything to that?
Kathy, I think we're getting a comment that it's time to wrap up.
Okay.
Oh, okay.
All right. Well, we have many more questions, all of which are good, but I guess we're supposed to stop. I couldn't. But thank you so much to my colleagues, to Lancet, and to the panelists, and also to those of you who hung in here and asked us questions. So thank you, and we'll look forward to hopefully good things coming from this document. Goodbye.